I'll try to share our screen, and just to let you know, Rosa, that we are here in Brazil, in São Paulo, a big university, probably, if not the most important ophthalmology department in the country, one of the most important departments. Our university is almost 100 years old, which is almost nothing compared to the universities in Europe, but Brazil is a very young country. And we are going to show you some history of our university in a video, and also some aspects of our department. Let me try to share the screen. That's okay? Thank you for So we started in
não para trás, não para o passado, mas para o português.
Em meio a grandes mudanças sociais, opressão à liberdade e o conhecimento sitiado, uma nova visão de futuro começava a tomar forma. Uma visão que privilegia a vida humana e a sua contínua evolução, confirmando que a busca pelo conhecimento e sua multiplicação de alta qualidade pode transformar o mundo de milhares de pessoas.
A preocupação aqui é com o futuro, com o que você pode trazer de novo, o que você pode trazer de inovação para o dia a dia, para a assistência, para o ensino, para a pesquisa, para a sociedade, beneficiando o último que é o nosso paciente.
E fazer com que esses conhecimentos que são gerados aqui, tanto em nível de ensino quanto pesquisa ou extensão para a universidade, eles se tornem de fato exequíveis à população do nosso país, né?
Assume para internacional.
A oftalmologia é uma especialidade que, para assistência, ela precisa de muita tecnologia. Nós temos a oportunidade de ter dentro da instituição um laboratório especializado em microbiologia que tem mais de 30 anos, e a gente consegue, com este laboratório, também prestar uma assistência e ter material para pesquisa de uma forma muito interessante e peculiar.
Quando a gente pensa em fazer uma pesquisa que envolve duas disciplinas, né, conseguir tramitar em duas áreas, na área básica, na bioquímica, na genética e na oftalmologia, facilita muito. Você tem tudo aqui que você precisa para fazer uma pesquisa de ponta.
Todos os departamentos que fazem pesquisa clínica, eles têm um reconhecimento internacional extremamente importante.
Você tem um tripé que na área médica ele é um tripé de sucesso. Então, atender o paciente dá a humanidade ao médico, o médico que ensina entende o que ele precisa pesquisar, o médico que pesquisa consegue ensinar de modo crítico.
A nossa filosofia é de que o programa de residência médica é muito mais do que o número de cirurgias e catarata que o médico residente foi capaz de fazer durante o treinamento. É muito mais do que a nota que o médico teve na prova nacional de título de especialista. E o nosso esforço diário é para que seja muito mais, né? A gente formar um profissional mais humano, um profissional mais completo, um profissional médico oftalmologista que saiba e seja capaz de exercer bem a sua função na sociedade.
85, 90 anos de pesquisa, e o corpo de docentes não se forma a cada 5 anos.
Pela visibilidade do nosso programa de pós-graduação, eu acabei sendo indicada para coordenar todos os programas de pós-graduação do Brasil. Isso só aconteceu, sinceramente, por causa da visibilidade que esse nosso programa dá. É o programa de oftalmologia mais importante do Brasil, que é considerado de excelência pela CAPES e que tem as maiores notas de avaliação.
Especificamente na oftalmologia, nós temos um cunho social muito grande. São todas ações sociais ligadas muitas vezes a projetos de pesquisa, e aí essa interface em que você está prestando assistência, mas ao mesmo tempo estudando o assunto e ensinando o aluno, aquele que está em formação, esse tripé assistência, pesquisa e ensino é o grande fundamento realmente.
Nós tínhamos um atendimento de cerca de 40 e poucos mil pacientes nessa época. E agora nós estamos atendendo cerca de 5 mil pacientes por mês. Nós pulamos de 40 para 60 mil.
O futuro é já, né? O futuro, ele não está chegando, ele já chegou e a gente precisa só enxergar.
Enxergar, agindo de forma a trazer esperança para todos.
Damos um espaço importante para entender mecanismos genéticos, mecanismos moleculares, terapia celular, terapia gênica, aspectos de inovação em tratamento e diagnóstico, sem dúvida, para que as pessoas portadoras de doenças raras, assim como aquelas portadoras de doenças comuns, como a própria catarata, recebam a mesma atenção.
A minha visão daqui para frente, sob o ponto de vista global, holístico, na oftalmologia, é de integração entre as diversas subespecialidades da oftalmologia e da oftalmologia com as outras especialidades da medicina. As manifestações oculares das doenças sistêmicas faz com que o oftalmologista seja cada vez mais atualizado na área médica, e a alta tecnologia da própria oftalmologia se destaca tão grandemente de várias áreas da medicina que torna a oftalmologia uma especialidade única, especial e apaixonante.
Quanto mais velho o paciente, mais ele precisa do oftalmologista, porque os olhos não foram feitos para durar mais do que 40 anos. Como o paciente idoso é cada vez mais frequente, a importância da oftalmologia, então, é muito grande nesse setor.
Escola Paulista de Medicina Unifesp. Ensino, pesquisa e assistência social a serviço da vida.
Thank you, Dr. Farah. Would you like to say a few words?
I would like to say that we are ready to start we already have many interrelationships, national and internationally speaking. And we would like to strengthen our relationship with you and your facilities, and also offer our facilities to you, and to exchange our experience and knowledge, because we have probably very different diseases going on in different countries and different managements, etc. And we do a lot of research and publications in our department. And this is something that we can also would like to go deep with you, Haza, and maybe in the future our two departments may get together and make a formal documentation that our university needs to start doing this regularly. So this is the main message that we would like to show a little bit of our department, a little bit of our university here in São Paulo, and get more relation with you. Thank you.
So thank you, Dr. Farah.
Another thing that I would like to mention is that this gentleman that you are seeing the left side, Moacir Álvaro, in the screen, was our first professor of ophthalmology in our department. He is the founder the founder of the Pan-American Association of Ophthalmology with Dr. Grado and Dr. Behrens. And this association is the Asociación Panamericana de Oftalmología, that includes all America, North, Central, and South America.
Mm-hmm.
And we start doing this since the beginning, our international relationship with Dr. Álvaro. And Rodrigo, if you allow me, let me show another short video that is going to show more details of our department, and then we go for the discussions and presentations and this with Dr. Rosa and our team. I hope you understand our Portuguese in the video, because the images also help to understand.
Yeah, I can
O nosso
understand.
presente é o conjunto de ações realizadas através de uma história que um dia foi apenas uma visão de futuro. Acreditar, ousar e realizar faz parte de cada página deste livro, que começou a ser escrito em meados de 1933.
O professor Moacir Álvaro foi um visionário que, desde a década de 30, trouxe para a oftalmologia brasileira novos ares. Foi um dos oftalmologistas mais importantes do século passado.
Sabemos da importância e responsabilidade com as iniciais que compõem o nosso nome.
É interessante que o nome CIMASP mantém a sua base, a sua origem no Moacir Álvaro. Quer dizer, as iniciais do Moacir Álvaro continuam no nome do Congresso.
A atualização médica oftalmológica, tanto para ex-alunos quanto para médicos da comunidade, é o nosso foco principal.
Nesses 42 anos de CIMASP, o conhecimento adquirido através dos estudos, pesquisas e criatividade estavam presentes em cada detalhe.
É um maior congresso que nós temos para a comunidade externa. A inovação no sentido de novidade aplicada estava sempre presente, sempre esteve presente no CIMASP.
A responsabilidade é grande, a quantidade de informações é enorme, o número de pessoas que nos procura também é significativo. Para que isso chegue para as pessoas, muita dedicação e muita seriedade, para que cada informação, em cada sala de aula, cada minuto, cada palavra tenha verdade, seja responsável e que as pessoas aceitam, entendam e que possam aplicar no dia seguinte na sua vida profissional.
Médicos que vêm aprender, que vêm trocar informações, que vêm se expor dentro do CIMASP também.
O CIMASP é um evento importantíssimo para o departamento, também por essa oportunidade de juntar novamente as pessoas e de confraternizar.
Nós criamos um tema abrangendo a parte posterior do olho. No entanto, o nome, Simpósio Internacional Moacir Álvaro, era muito longo. Então nós utilizamos as 4 primeiras letras e colocamos SP minúsculo, que significava segmento posterior. E o CIMASP ficou Simpósio Internacional Moacir Álvaro, São Paulo. Na verdade, mas a origem do nome era segmento posterior, porque o simpósio era temático.
Esse simpósio, iniciado há 40 anos atrás pela minha geração, continua firme, continua forte e traz essa marca: grande internacionalização, alto nível de ensino e aplicação da pesquisa que é feita em benefício da sociedade.
42º CIMASP, uma sinergia entre passado, presente e futuro, que seguem juntos, mantendo as bases sólidas do conhecimento, ética e valores, aliados à coragem e ousadia para inovar e fazer melhor o que já é um grande sucesso.
This is our staff in our department. It's a big department, as you can see. So the time is all yours, Rodrigo and Rosa. You coordinate the session from now on. Thank you so much.
Okay, thank you, Dr. Michel. First, I'd like to thank Rosa for accepting the invitation, sharing her time with us. Rosa is a world-known retinal specialist. She has published more than 100 peer-reviewed articles, and with special emphasis in multimodal imaging and the correlation with histology. And we thank you very much, Rosa, and now you can start sharing your screen and give your lecture.
Thank you so much for your invitation, and thanks for sharing all these beautiful videos, because I think you have a great department, really huge compared to our department, which is a smaller. We live in a smaller city, Valencia. It's 1 million population only, so we cannot really compare that much. But thank you so much. It's my pleasure to share my time with you all. And I think it's great that you have all these opportunities of learning for the younger people. And we discussed some topics that we could present today with Rodrigo. And we thought the clinical pathologic correlations in AMD could be an interesting topic. I'm focused more today on the macular atrophy part, but we have been working for the last years in many different cases. And we have been working in collaboration with Genentech and Daniela Ferrara, that you all really well known. And also, of course, with the mentoring of Dr. Curcio in the University of Alabama and Dr. Freund in New York. I have been lucky to be working with both of them in all these papers. And I think it's a really interesting topic, because the kind of research that we have been performing for these papers and all this research, it's quite unique. So what we do is we collect cases with multimodal imaging in vivo in the clinic with Dr. Freund in New York. We have different modalities: multicolor imaging, autofluorescence, angiography. We have, of course, OCT. And then the patients, some of them, they start a donor program. So when they passed away, they donor the eyes, and the eyes are collected normally really quick, in 8 hours or less. They are prepared, and they are imaged with this using the eye tracker of the spectralis, doing ex vivo OCTs. So they import the in vivo images of the patient into the device, and they hold the eye in a holder, and they put the eye in front of the device, and the device is able to do eye tracked images to the in vivo images, ex vivo. So that, I think that's quite unique. And then the preparation of the histology is performed based on this type of images. So they perform ex vivo images on the OCT, and the alignment of the histology is done based on these ex vivo OCT images. So then what we have in the histology is what we can do like the closest way to get a correlation of histology and OCT. So what we are going to review today, it's all based on this type of technology or research. And also Dr. Curcio is able also to do more multimodal imaging, also ex vivo. For example, here a color fundus image, and also here an autofluorescence with near infrared autofluorescence. And I'm presenting the next slides as questions that we are going to try to answer with the following slides. So in macular atrophy, Do you think choroidal hypertransmission always correlate with the area of RPE atrophy? Because normally we define in the OCT macular atrophy as choroidal hypertransmission. And the second question is, the RPE has a well-defined border or it's more a ragged border? Do you already know? So we are going to review some images. And as I was saying, normally nowadays we use OCT to quantify, to diagnose macular atrophy or geographic atrophy. And we know, thanks to the CAM group, there are many papers coming out, that OCT is really useful in this type of patients, not only because it's 3D, but we can also see the layer that it's affected. We can differentiate if it's only outer retinal atrophy called aura, or RP and outer retinal atrophy, which is called RORA, and differentiate that. We also can detect really early changes like nascent GA, and we can also see neovascular signs associated with these atrophic findings. So OCT nowadays, it's a really useful technique in order to diagnose macular atrophy. But if I choose this case, will you be able to line where's the border of the atrophy? Normally, when we talk about OCT, we talk about choroidal hypertransmission. When we lose the RPE, we don't have the absorption of the light because of the RPE. So we don't have RPE and the light comes through because there's no RPE. But in this case, we see a continuous line over the area of hypertransmission. So it's quite difficult to really point the border of the atrophy in this case. And let me show you another case. If you try to point the border of the atrophy in this other BS scan, you don't really see an area of clear choroidal hypertransmission. It's more like a barcode with some lines of hypertransmission, but we see that there's disorganization of the outer retina above this area. So we know that there are signs of atrophy, but it's quite difficult to really line where the RP ends and where we have atrophy only with the OCT. If we correlate with histology, we will see that the RPE ends with some proliferation of cells. It's not really defined. And in fact, the area of atrophy is not ending here, but here, where we have some cells of the RPE here. And there are other points where the RPE ends in correlation with the atrophy of the photoreceptors. And what we can use to define the border of the atrophy. So in histology, normally they don't use the RPE because it's quite difficult to know where the RPE ends. They use this line, the line that I have been showing here, again with a green dot, and again here with a green dot. And what's that? That's the ELM that ends in a curved line, and it's called ELM descent. And it's not that I have invited that. Already the SARCs in Australia, they describe this ending of the ELM in a curved shape in the areas of atrophy. So they describe that the RPE cells, as I have been discussing, they proliferate when they go through the border. We have also progressive degeneration of the photoreceptors, and the ELM ends in a curved line that it's going to touch the basal lamina deposits and the Brooks membrane. And we have also outer nuclear layer disappearing below this area. So the ELM descent is like the border of the photoreceptor atrophy for the histology images. So we wanted to know if we can see this border on the OCT, and we matched different borders in a patient with histologic images. and we were trying to see this ELM descent at the borders using OCT and correlating them with the histology. And we saw that in 9 different BE scans, we saw 2 different borders at each side, and all the ELM descents were visible. We didn't saw any sign of ELM in the area of atrophy, of course, because we lose the outer retina. And this ELM descent was only visible on OCT, but not visible on color fundus, autofluorescence, or if we had low quality BE scans. So we think that the ELM descent is useful also as an OCT marker of atrophy when we don't really know where to place the border of the atrophy using only the choroidal hypertransmission. And it's important to differentiate that ELM descent means photoreceptor atrophy, but not RPE atrophy. It's related, but it's not the same. And what happens if we follow this ELM? Normally, we are used to see this type of patients at the end stage where they develop outer retinal tubulation. And we know that this is a neurodegeneration really advanced. And in this other paper, we were able to track the origin of this outer retinal tubulation in order to see what was at the beginning. And we saw that we have different shapes of the ELM. It could be flat, then curved, then reflected, and then it scrolls, and that's when it forms the outer retinal tubulation, okay? And we also saw that this is a progressive stage, so they move from flat to curved, then reflected, and then scrolling. But once you are in a scrolling stage or shape, there's a higher risk for these borders to become already outer retinal tubulation. So we thought that maybe when you see a scrolling ELM, it's a point of no return, and these patients are already in a neurodegeneration process that we cannot really stop. And this could be important for clinical trials where we try to stop geographic atrophy, or clinical trials where we try to stop the atrophy in patients like choroideremia, where we see a lot of outer retinal tubulation. So coming back to the questions, the histologic border of the photoreceptor atrophy, which is called ELM descent, we can see this border in the OCT and may be a useful clinical marker of photoreceptor atrophy where we cannot place the border of the atrophy with only the choroidal hypertransmission. And on the other hand, outer retinal tubulation, it's an advanced sign of neurodegeneration with involvement of Mueller cells because the ELM is involved. Maybe, do you have any comment or I continue?
Do anyone has any comment or question? I think you can continue, Dr. Hauser.
Okay, so we continue with another case of macular atrophy. And now the questions are, if
Hauser, I have one question.
Yeah, sure.
What is the clinical significance of the tubulation? What makes us change our management? You showed several kinds of tubulation.
Yeah.
Is there any kind of tubulation that will change our management? Because people usually, it's a confounding factor that people sometimes think is cystoid space or sign of activation of leakage, etc.
Yeah.
But you showed several different kinds of, and what does it mean clinically or in terms of changing our management in this situation in a very practical way?
Yeah, so I think you pointed the most important thing for outer retinal tubulation, which is differentiate this sign of neurodegeneration from exudation. It's not exudation. although we can have fluctuations of fluid within the tubulation. But I think the clinical importance is that these type of patients, they have really low vision. We cannot really offer many reconstructive or restorage of the retina because they already started a really advanced neurodegeneration process. And we don't have right now any therapy for those kind of patients. That doesn't mean that we don't have to treat these patients if they are doing well with the intravitreal therapy, if it's associated with neovascularization. But I think those patients have a really severe disease, and visual acuity normally is really low.
So you can see both things: activation with cystoid space and fluid plus tubulation. And you're not going to treat the tubulation, but you are going to treat the other things that come along. But if there is only tubulation, then you can usually only observe. Is that right?
Okay, good.
Okay, thank you.
Thank you. So moving to the next case, we will see that this case has hyperreflective plaques over Bruch's membrane. And I wonder if you know already what that means. Also, what are the hyporeflective drusen or ghost drusen that have been described as refractive drusen also, and what's the hyporeflective wedge around the atrophy. And we were really lucky because this case has all these signs, and we are going to review in the multimodal imaging all these features. So we see that this patient, it's an 86-year-old woman, neovascular AMD in the fellow eye and no signs of neovascularization in this eye. And we can see that there are many subretinal drusenoid deposits all over the macula, and we can see those lesions are as hypoautofluorescent here in the short wavelength autofluorescence, and also here in the near infrared reflectance. We see that this patient also has an area of atrophy of the RPE and the outer retina. And we can see the correlation with the BS scans. So we see with the tile arrows here, the subretinal drusenoid deposits or reticular pseudodrusen. They are located above the RPE. That's why they are also called pseudodrusen. And as we were already discussing, we see hypertransmission, which means we have atrophy of the RPE, but also the outer retina, so RORA. We also have hyperreflective lesions here in the near infrared that correlate with hyperreflective plaques above Bruch's membrane. We have some areas of soft drusen, and also one hyporeflective drusen or refractile drusen, and the hyporeflective wedge, which was described by Dr. Jordi Monés some time ago at the border of the atrophy. In this case, we also had some follow-up over time before the patient passed away, and we saw that in only 8 months, a clear progression of the atrophy, and in other areas where at baseline we didn't have any atrophy, the patient developed areas of complete atrophy of the RPE and outer retina. And this is the near infrared showing the area of atrophy at baseline and 8 months after, which means 4 months before death. What we saw in histology first was that when we saw this hyporeflective wedge that could be also misdiagnosed as fluid and treated not really correctly because it's a sign of atrophy, not a sign of exudation. We just saw that this is a reorganization of the Henle fiber layer and the outer nuclear layer. That it's pointed here. And in this case, we also, as we were mentioning, we saw a lot of subretinal drusenoid deposits that was seen on the histology as widespread extracellular material. We see another area here of the border of the atrophy with the ELM descent and the reorganization of the Henle fiber layer and the outer nuclear layer correlating with a wedge shape. And also we saw subretinal drusenoid deposits both in the histology and the OCT, soft drusen here. And what I was mentioning before, the hyperreflective plaques that sometimes are really touching the Bruch's membrane, and we cannot in the OCT differentiate those lines from the Bruch's membrane. But in histology, we clearly see that those lines are floating in the material, and they correlate with cholesterol crystals. This is another case where we see this hyperreflective plaque, and it correlates clearly with this cholesterol crystal. And we were able also to differentiate in this case soft drusen from calcified drusen or refractile drusen. And I think this is really important in the clinic because we really know that many patients have soft drusen. We know that we have risk for atrophy and risk for neovascularization. But when we see calcified drusen, it's completely different. So prognosis for these patients, it's going to be completely different. We see that the appearance in the OCT is different. Both are drusen, but the content is different. With drusen, we have a hyper-reflective content that it's quite homogeneous. With this type of refractile drusen, we have a hyper-reflective content with a hyper-reflective core above. And this core correlates with calcific nodules. And this was also published by my colleague Anna Tan in Singapore and the group by Dr. Curcio and Dr. Messinger. And they correlated this calcified drusen with the risk of atrophy. So it's really important to recognize this type of soft drusen that became calcified because this hyperreflective core is quite characteristic. But in these lesions, we are always going to see areas of atrophy of the RPE. So this type of drusen, they are a marker of atrophy of the RPE. So it's not the same having soft drusen that having calcified drusen or refractile drusen. So again, in macular atrophy, we know that the hyperreflective wedge shape correlates with a reorganization of the Henle fiber layer and the outer nuclear layer. The hyperreflective plaques that we see above Bruch's membrane correlate with cholesterol crystals. And the hyperreflective drusen correlate with the multilobular calcific nodules that we see in this refractile drusen. And this means an end stage of soft drusen, and they are a marker of progression to geographic atrophy. So it's really a progressive biomarker that we have to keep in mind. Any question for this case?
Yeah, I have a question. Very nice talk, Rosa. Have you studied the extracellular matrix on those patients, specifically proteoglycans?
For which type of patient?
If this macular atrophy patients with macular atrophy on the edges of.
For example, in this paper, Anna Tan, they perform a really detailed analysis of all the content. But for example, subretinal drusenoid deposits, we didn't perform this analysis specifically for this case, but there are many papers, especially by Dr. Curcio, regarding the content and the difference between the content on subretinal drusenoid deposits compared to drusen, and the difference between esterified and non-esterified cholesterol and all these things. But it's not specifically in these papers.
And in patients with macular atrophy, do you think on the edges of the atrophy, you might have some changes on the vascular, the microvascular of the retina? Because we did some studies with OCTA with Daniela and Jay Duker, and we saw that there is increase on the flow on the edges. Have you seen anything on that on the histology?
I didn't look for that, but maybe, yeah, we can talk to Dr. Curcio to review that.
Thank you.
I think it's also important to plan this type of analysis because of maybe the staining could be different if you want to analyze vascular structures. The type of staining that it's used for this type of analysis is willing to keep all the subretinal, like the drusen material, as intact as possible.
Yes.
So they use electron microscopy stainings in order to use then optic microscopy, but the reason is to keep all the drusen material.
Rosa, recently we had one of our rounds a sort of a doubt about the subretinal drusenoid deposits, and you can have clinically two manifestations: the dots and the ribbons.
Yeah.
And to understand dots as a subretinal material is easy. What about the ribbons? What are your thoughts about where is located that deposit?
I think, well, the deposit is located in the same space, in the subretinal space. The thing is that when these type of lesions go widespread in the macula, you have to, I always think on these lesions like pyramids, like touching the photoreceptors and eroding the photoreceptors. So over time, all this material with the photoreceptors become like more diffuse. And that's when you have this kind of lesions, more like with atrophy of the outer retina. And I think the material is more widespread instead of located in more like a dot. Okay. But it's clearly in the histology, in papers by Dr. Curcio and Dr. Spade, they describe really like it's really different compared the material of the subretinal drusenoid deposit compared to photoreceptor material. So they can differentiate really well the material.
Thank you.
Okay, and these cases are a little bit different because the technique that I described before with a direct clinical pathological correlation, we didn't had any case with direct correlation of choroidal cavern and histology. So the approach is a little bit different, but we try to understand what are the choroidal caverns. And one of the questions that arised was if the caverns are always choroidal, always located in the choroid, and also what are these type of lesions? Because as you know, choroidal caverns were described by Dr. Kerkes quite recently as hyporeflective structures in the choroid, and they hypothesized that maybe they correlated with ghost vessels in the choroid or stromal pillars of the stroma of the choroid. But we were not that happy with this hypothesis, so that's why we were interested in this type of lesions. This is an example, 80-year-old male with geographic atrophy. We see that the infrared reflectance shows the choroidal vessels, but we can highlight some dots, hyper-reflective dots here. And if we correlate with the unfast reconstruction of the OCT, we will see that these hyper-reflective dots correlate with hyporeflective structures, always located along the vessels, next to the choroidal vessels. And this seen on the B scan, we see a hyporeflective area with a hyperreflective shape. So we try to correlate these lesions with other structures that we see in the eye, and I thought that this was quite similar, where in cases where we use silicone oil as a tamponade and we have intraretinal silicone oil, we see the same image. We see a hyporeflective structure with hyperreflective tail. That's why we started to analyze or think and study how the lipids are showing in the retina. And we review a lot of papers in the literature, and we know that depending on the size of the droplet, the appearance of the lipids is going to be variable. So sometimes it's reflective, sometimes it's non-reflective. But we also know that the light is more absorbed by the blood within the vessels. That's why we see hyperreflectivity here in the OCT, and it's less absorbed by the lipid. So here we have less absorption, and we have hypertransmission. And how we can have hypertransmission? Maybe because an optic effect. So we have less absorption here compared to the tissue around. That's why we see hyporeflectivity. And also we have a transmission tail that could be explained maybe by a lensing effect, or only because of the less absorption. And talking to Dr. Curcio again, she referred that there are lipids in the choroid that were already described by Dr. Friedman in 1966. So we already knew that in the histology of patients, we can see droplets of lipids that are called or are described as choroidal lipid globules. And these globules are seen in normal eyes. And also, it's more common to see this type of globules in eyes with aging signs, and also in eyes with diabetic retinopathy. So we collected cases with choroidal caverns in the clinic, and also cases with lipid globules in the histology. In the histology, we saw that globules were present in 42.3% of the donor eyes with normal maculas. You know that Dr. Curcio has a lot of eyes to be studied, so she performed this study. And also some funny things that we saw in this kind of patients is that the lipid globules are not only located in the choroid, but also they track the neovascular tissue in cases with neovascularization. So we can see here these globules in the choroid, but also tracking the neovascular membrane in the neovascularization in a case of AMD. And we can also see this type of lesions in the clinic. So if we track this patient with a neovascular AMD, we can see that we see these hyporeflective structures with some kind of tail. So this type of globules or caverns can be seen not only in the choroid, but also tracking the neovascular tissue. And if we see this image, that it's an unfast reconstruction of the histology with veins in the choroid, also the arteries, and the globules here as like green dots, we see that it's quite similar to the images that I was showing previously on the unfast OCT. So we see the vessels here, and we see next to the vessels these hyporeflective lesions that we have been describing. That's why we thought that the caverns really match the globules, and all the information we have about the lipid globules in the choroid, and not only the choroid, but by other tissues in the eye, really match also what we see in the clinic. We saw that lipid globules are more frequent in the choroid, but we can see also this type of lesions in the sclera, and as I already mentioned, in the sub-RPE space between the Bruch's membrane and the RPE. They are always extracellular and extravascular, and they could be as large as a vessel. So they could be really big. And the important thing is that these type of lesions, they don't show any sign of inflammation, so they could be really physiologic. That it was already described by Friedman in 1966, where they saw this type of lipid globules in normal choroids. So also in cases of macular atrophy, but not only in that, because we have been also describing this type of lesions in central serous choroidal retinopathy and other cases, we see that caverns are non-reflective spherical structures, that they always have this tail of hypertransmission that it's quite characteristic, and there's no evidence on the OCT of flow signal, so we don't think they correlate to ghost vessels, but to the lipid globules that we know that are extracellular, always extravascular, and they are lipid. They are found in normal eyes, but also in AMD eyes or eyes with diabetes. And they are located primarily in the choroid, 70%, but also located in the neovascular membrane and in the sclera. So I think it's a lesion that we still have to find a case with a direct clinical pathologic correlation, but I think we can really say that it's correlated and they have the same characteristics. So we have been seeing that the ELM descent could be an OCT marker of the atrophy of the photoreceptors, and we can clearly see with nice examples in the OCT when the quality of the BS scan is good enough. We have been also reviewing that the hyperreflective plaques that we see above Bruch's membrane correlates with cholesterol crystals. The hyporeflective drusen, we know they are a biomarker for progression to geographic atrophy, so we have to clearly differentiate this drusen from the classical soft drusen. And the caverns could be good correlate in the clinic to the lipid globules, but we still have to confirm that. And well, that was just a thank you for the invitation. And it's been a pleasure to talk and share with you this multimodal imaging with histology correlate studies. Thank you.
Thank you very much, Rosa.
Very good.
So we can move now with the cases. We have.
Rodrigo, can I make a question?
Okay, go ahead.
We published some time ago some patients with wet AMD that they have scar, and over the scar they have, like on OCT, the hyporeflective spaces that does not change with anti-VEGF injections, but it's intraretinal. Do you think this kind of lesion can be these lipid dots?
Intraretinal?
Intraretinal, over the scar.
Yeah, I don't know if intraretina could be lipid globule. So without seeing the image, I don't really know. I know they could be located in different areas in the eye, subretinal or sub-RPE, choroidal, and sclera. I've never seen an scleral case in vivo, only in the histology, but I've seen in different locations. I don't think I've never seen something intraretinal.
Yeah, because there definitely is not fluid, because we did a monthly injection and there was no change.
But it could be like a space, like a cystic space.
Yes, that was
like
our
degenerative space. So
yes, that was
yeah.
our hypothesis.
Mm-hmm.
Eduardo, can you share your screen and start your case, please?
Yes. Let me see if I can get it. Can you see? No.
You have to share desktop.
Wait. Share. Yeah. Okay.
Can see now.
Okay. Can you see the case?
Yes.
Yeah.
Okay. No, it's not related, but with the Rosa's fantastic talk, but I had presented this case in the past, together with Max D'Amico, and this is a 24-year-old, very healthy Brazilian female, which came to Max D'Amico at first, complaining of loss of central vision in her right eye. The left eye is completely normal. This is not our point to discuss. The right eye, as you can see, that was in this March 20 last year. She's a mildly myopic woman, and she came with 20/40 vision and this kind of a very mild myopia. And to see the fundus a little bit better, we have this photo showing more details about this funny picture. We can see pigmentation, maybe alterated pigmentation around the disc, hypo and hyper, very irregular right here, and also some kind of hypopigmentation at the fovea. The retina around the fovea at this time looked normal. But this is very important to remember this case because this kind of finding around the disc may make us a little bit concerned. And I advanced that this patient is not highly myopic. The eye was not very elongated. So this is not related to myopia. And also, there was no history of previous trauma. So you can see here the autofluorescence, very funny, this kind of reticular pattern. And most interesting now is when we saw this kind of autofluorescence demonstration, not correlating very well with the findings in the color photos. But we can see here, everybody is seeing lots of dots, spots, as you want, around the posterior segment of this eye. So you have this kind of presentation, this kind of pigmented alterations associated with this kind of this is autofluorescence pictures. You can see the diffuse distribution of these lesions. And again, fluorescein angiography was very important because we could see here confirming little dots at the early stage of the angiogram. So you can see also very important signs, very evident signs of inflammation in this case. So that is why I'm showing, the more you see the case, the more you see different signs, like you have periphlebitis, you have a hot optic disc, and also phlebitis at the periphery of this eye. So pay attention also to this kind of lesions that was found in the inferior, let's say, in the peripheral retina, but inferiorly. These two lesions that would be, I think, difficult to see only with color photos and other types of multimodal imaging. So with these findings, I'm not going to show you now the OCT because there's a reason for this. So myopic patient, mild myopic patient, granularity of the macula, very hyper auto dots and spots, early hyperfluorescent dots, this kind of findings, optic disc, vasculitis, maybe choroidal lesions. I ask you, what would be the best diagnosis for this case? Not sure. Don't ask me for the OCT now, because this is a kind of training, and because of Rosa. Rodrigo, how can you want me to go ahead? But I would like to have some comments.
Okay, I think we can think about an overlap of mutes and multifocal choroiditis, but a typical, because you have phlebitis associated. You have the spots in the autofluorescence, the foveal dots that you could unilateral, that you could say it's more resembles mutes lesions. But then you have those punched out lesions in the inferior part of the retina that and this hypo-reflective halo around the disc that are more related to multifocal choroiditis. So I would say it's an overlap between those two.
Can I have Rosa comments?
Well, I completely agree with Rodrigo, because the images above, they fit completely with mutes, but we have peripheral signs that they don't fit really with the critical description of mutes. We know that some mutes are quite atypical, so it's more like a spectrum of multifocal mutes disease.
Yeah.
And yeah, we are willing to see this phobia, I think.
Eduardo, you don't have even more peripheral aspect.
If I have more to show you?
More peripheral areas.
No, I think the most important areas are shown here. So the question is, I'm pressing you to diagnose, of course, mutes. That's why I'm trying to present this case like this. But the good question is, who came first, mutes or multifocal choroiditis? That is why the next slide I put this. I mean, just to let us very confusing, because this is something that we have been seeing since last year. I never thought that mutes could be associated with the multifocal choroiditis. Okay, anyway, this is what we should call an overlap syndrome. In other ways, people with multifocal choroiditis can demonstrate activation of the multifocal choroiditis through mutes. Mutes is today it's a kind of syndrome. I'm not talking about the flu that Januzzi described. Mutes can come together with systemic diseases, very bad diseases. So this is best called multifocal choroiditis, mutes, overlap syndrome. Now, if you don't believe me, this is something that I came just to show you, because this is being described by someone that you can see here in this case, the granularity. This is at the when the patient first presented. You can see, of course, the alterations of the ellipsoid layer, and this is something that I didn't know what this could represent at this time until I saw a paper. So this is a sign that we see in some patients, but it's very rare to see in mutes. But this maybe it's a confirmation that this case is really a multifocal choroiditis with activity, because it was described by Rosa last year. She was able to show in the literature very nicely this kind of, I think ours is even more evident, but Rosa showed this case. I mean, in most of the patients, 3 or 4, 2 or 3, they were highly myopic, and she didn't. She didn't pay attention to the choroid thickening, or that we can see in our case. Okay, but this is a sign of activation, and the explanation is difficult because she doesn't know what this kind of a vertical hyperreflective lesion. She was not able to say 100% what they represent, but maybe inflammatory cells inside the retina. They can go from the RPE to the internal limited membrane, and this is a sign, according to Rosa, of activation of multifocal choroiditis. That our case, this is our case, this is Rosa's case, our case also show it. So the name is 4. So watch out now when you listen to someone saying, oh, this is 4, means foveal outer retinal, as you see here. Rosa, do you agree or not? Or this is all related with mutes?
Well, before Rosa speaks out what she thinks, it's when you study retinal, the cellular structure that comes across all the retina is the Miller cell. So maybe something related to a Miller cell pathology associated, because you can see it coming from the inner retina to the outer retina in a vertical way. I don't know exactly what this is. It's just a guess. So now let's hear what Rosa thinks.
Yeah, I think also the difference maybe is the evolution of this. I don't know the evolution of your case, Eduardo, but what we described in this series of cases with multifocal choroiditis is that this hyperreflectivity is quite severe and is there for many, many months.
Yeah.
So
that is why, yeah, go ahead.
Yeah, that's the difference between mutes, this columnar hyperreflectivity typical of mutes, and this hyperreflectivity in cases of multifocal choroiditis. And also this type of patients were really a specific subset of multifocal cases, because the visual acuity was quite severely decreased compared to other cases with multifocal choroiditis, where you don't really see that much decrease in the vision.
Yeah, that is why I'm asking you if you agree. So my question is, this could be only related to mutes, very, very atypical. We don't see, we see those kinds of vertical lines, but not coming from the RPE to the internal limit membrane. And also this patient, she shows a lot of details of more in favor of multifocal choroiditis. So that's why I bring this case. But the only thing that I can tell you, I'm going to show in 3 or 4 weeks, and then we lost her of follow-up. Okay. She came with the vision better. That's why it's a little bit different from your follow-up. I have seen your cases. Okay, let me show you, just to let the people know that in 2002, those guys, of course, Bailey Freund was here, and this is Daniela Costa from Brazil. They already showed this kind of association, but before them, the great Donald Guess in 1992 had already described this kind of association. Mutes and multifocal choroiditis. And just to show you, three weeks after, we gave her a little bit of steroids. The vision was 20/40, but she was getting better. So it's you have things that in favor of mutes, and of course the lesions around the disc, the inferior lesions make us more concerned about choroiditis. So this is the follow-up. You see here, not much different because only 3 weeks, but the vision was getting better. And of course, with lesions, the going away. And this is Rosa. That's why this is almost after 1 month. So a lot of things related your with your findings.
But also, Eduardo, I think if you see this optic nerve in a case, even if you have overlap of mute signs, I will think on multifocal choroiditis.
Yes, you're right, because you know Iannuzzi, everybody believes in Iannuzzi. He says you need a hot optic disc. If you don't have optic disc staining, okay, stay away from multifocal choroiditis. But I'm saying this is something that we have seen in Brazil now. People present mutes, but also with some kind of signs. I don't know, but this is because of you. This paper is fantastic. I was reading yesterday, but thank you. This is my case.
Thank you.
Thank you, Eduardo. So, Otaviano, can we start?
One more question. What do you do with the patient? I think we have to be practical as well. What did you do? What kind of treatment do you do? What was the follow-up? What happened?
What I did, I called Max many times because this is Max patients. I said, Max, go ahead, try to find this girl, and we need to follow up her. We need the follow-up of this lady. And the only thing that I have is what I just showed. But this is a patient that I would like to follow very near, because
if I were the patient, I would ask you to do something. Can you do something to me, doctor, or just differential diagnosis? Can you help me with something? Can you treat me or not?
What do you mean, Michel? You're in favor of mutes or multifocal choroiditis?
You can do something, Eduardo, because when the patient look for us, the patient needs something, some help. What can we do? Not only the differential diagnosis. You know what I mean? What can we do to help the patient? Is it possible in this situation or not?
As I was telling you, I never saw this lady. Max asked me for opinion, and I was saying to him that this is not only mutes. But that was last year, and I was not aware of this finding. I mean, of the 4. So the only thing that I would do with this patient is to follow, to tell her that she needs to observe the vision, floaters, and to see in which way she's gonna do multifocal choroiditis or mutes. Mutes is benign.
So no treatment was done.
For 5 to 7 days, 30 milligrams of corticoid because of the findings. But she's fine.
Thank you, Eduardo. Could you share your screen so Otaviano can start sharing his screen and present his case?
What do I do here? Stop share, right?
Yes, please. Thank you. So now Otaviano is going to present his case. Otaviano is a good friend, and he's also the head of the Retina sector in our university. Please, Otaviano.
Are you seeing my screen right now?
Yes, very well.
Yeah. So first of all, I would like to thank Dr. Rosa for the kind acceptance of participating in our weekly Retina meeting at our university. My clinical case is about a male patient who came for a second opinion since he had a diagnosis of retinal drusen. He had 20/10 of vision acuity with 5.5 degrees of myopia and 2 degrees of astigmatism in the right eye, and the left eye he also read 20/20 of vision with 4.75 degrees of myopia associated to 1.25 degrees of astigmatism. In the retina, we saw in 2016 yellowish, well-defined subretinal lesions diffused through the posterior pole and also to the periphery. This kind of drusen appeared as clusters of multiple yellow and pale spots. In red-free analysis, the size and the spatial density of this kind of drusen were comparable to the retinography exam. In the fundus autofluorescence, these drusen were characterized by a hypoautofluorescence center with a hyperautofluorescence margin. The number and the spatial density of the drusen of autofluorescence imaging were considerably greater than the color photography. However, individual drusen appeared larger on color photographs comparing to the fundus autofluorescence. In this tomographic reconstruction, we can see several areas of the material under the retina pigmented epithelium. In the right eye, we can observe shallow elevations of the RPE, lamellar bands with drusen internal contents difficult to discern, drusen of triangular morphology, characteristic resulting of C-tooth appearance, and hyperreflective internal contents. In high-resolution OCT mode of the right retina, we can see confluence of this material, mound-shaped elevations of the RPE with hyperreflective internal contents. We could observe similar lesion in the left eye, shallow elevations of the RPE, drusen of triangular morphological characteristics, and hyperreflective internal contents. Also in the right resolution OCT modes of the left retina, we can see mound-shaped elevations and RPE lamellar bands with hyperreflective internal contacts. The patient came back in 2017 for follow-up. We observed apparently the same lesions without having had no major modification in both eyes. In 2018, patient complained of bilateral diplopia. He underwent to a several central nervous system imaging exams. All of them were normal. His general ophthalmologist prescribed the 5-diopter bilateral temporal based prism, and he had the diagnosis of adult strabismus. But when he came for my assessment, I saw this hyporeflective imaging next to the drusen and under the fovea area. When we compare the exam from 2017 to 2018, we can see this difference well in the retina, in the right retina under the fovea. When we analyze this lesion in the high magnification mode, we could observe better the remodel of the drusen lesion, and in 2018 OCT, this hyporeflective image around the drusen. You assumed the image may be a new vascular membrane. So we performed the OCT angiography exam at this time. Unfortunately, we were not able to see any type 1, 2, or 3 new vascular membrane in this right eye. And also, we cannot see this kind of lesion in the left eye. 2 months later, he returned to my office saying that he preferred the old glasses without prism that was no longer able to adapt to the new worn glasses. We performed the other OCT image and we can't see the hyporeflective lesions. So in high magnification mode, you could observe again the remodel of the drusen lesion and the disappearance of these hyporeflective images around the drusen. The patient came back in 2019 for follow-up. We observed apparent changes of the drusen lesions without having any hyporeflective image in the right eye. So I would like to ask some questions to Dr. Rosa about this very beautiful paper which she had published in Co-Authors in Ophthalmology. First of all, if she agrees with our diagnosis of type 3 cuticular drusen for this patient, At second, if it's possible to comment on the intriguing description from the discussion when you said first, cuticular drusen, like hard drusen, begin as small nodules of hyalinase protein-rich materials external to RPE. Second, with time, cuticular drusen can remodel, regress, or increase in the size and number. Cuticular nodules that enlarge undergo a biochemical alteration. The disintegrated appearance of the electron microscopy is possible to result in a suboptimal preservation of the extracellular lipids. Using soft drusen formation by retention of lipoproteins as model, it is possible to hard and cuticular drusen are both retentive matrices that permit conversion to soft drusen over the standard periods. Third, cluster of the cuticular drusen evident join result in a continuous deposit that consists of substantial biophysical diffusion and transport barrier between RPE and color capillaries, and needles for inflammation increase the risk of complications as portrayed for soft drusen. And third, if she thinks that these inflammatory changes may be the cause of this patient's exudation, perilesional fluid, and diplopia complaint. Thanks so much.
Thank you. So I think it's a really nice case of cuticular drusen. I completely agree with you in the diagnosis, especially because if you go back to the autofluorescence, that's really typical, the target lesion of the autofluorescence. I think it's the most, maybe one back because this is magnified and it's, yeah, this lesion is really typical. And you can see that the cuticular drusen, it's really widespread, and you see that especially with the flood illuminated camera, when you use SLO based autofluorescence is less evident compared to flat illuminated cameras and filters, the spade filter. So that's the best way to see the cuticular drusen. And also, if you had fluorescein angiography, the image is really beautiful with the sky, stars in the sky description that Dr. Gass performed. So I fully agree with the diagnosis. The second question was, maybe we can answer the third. Yeah, because I think some drusen they associate with some kind of fluid, and I don't think this relates to inflammation necessarily, but yeah, there are changes in the shape of the drusen and in the content. What I don't really understand is why this tiny amount of fluid with any other sign is causing that much diplopia that needs 5 diopters to be corrected. So I don't fully understand the clinic, and without seeing the patient, I don't really know. But 5 diopters is quite a big correction. Yes. So I don't think if you can fully answer all the complaints of the patient, but by only this tiny amount of fluid in the center of the fovea. I don't know if the other people agree.
Yeah, do you see this case of cuticular drusen? Sometimes they have this decrease of visual acuity in the center, or some peripheral scotomas that become better in the time. Do you see this kind of complaint of the patient? Because sometimes you can see these fluids and the patient complain a little bit, but this patient, I saw this, and it's an intriguing case because I didn't know why this patient preferred a prism, and sometimes 2 months after that, they don't prefer more.
Yep. I agree. I mean, sometimes they could refer some changes in visual quality, but I don't think the diplopia is fully explained by this OCT.
Because the diplopia is too big to, the correction is too big to be related to this. I think that do you do a external motility examination or a neuro-ophthalmology examination and everything was normal?
Yes, everything's normal. This prescription was being made by strabismus specialty, so it's a tricky case. But I only see this difference because all other exams were normal, and after that, after 2 months after that, it becomes totally normal, and we will not see more the strabismus.
Yeah. Just Otaviano, I think that you should not relate 100% with this finding. Some people come with the diplopia and goes away, and he's young, but I don't see any correlation with the even if there was a kind of a macular destruction, it's not related many times, most of the time with diplopia. This is it's a macular muscle problems and fusion, etc. In my opinion.
Well, I've seen diplopia with but very small, and it's not exactly a diplopia. It's almost a diplopia. It's like a ghost image, but not exactly a diplopia that may be caused by this.
Yeah, we don't see this also with the AMD. We can see patients, especially women at after 50-year-old, they can develop a kind of dystrophy in the macula, a pseudovitelliform appearing of the macula. The vision is not so bad, but you can see this with the corticular drusen. But right now, because of Januzzi, we can understand much better the corticular drusen that all of us thought in the past that was benign. It depends on the classification, and your case is fantastic. Is classic.
Wonderful.
Thank you, Otaviano. Very nice case.
I think Rosa wants to say something.
I'm going to start sharing my screen, and I'm going to be quick, and then afterwards, Danielle finish the meeting. So it's a very quick case. It's a 76-year-old male that complained of worsening in the visual acuity in both eyes. He had a history of smoking. His vision was 20/80 and 20/63 in the left eye. And so this is the right.
Cannot see.
Yeah, we only see the first slide. Yeah.
Yes, I think you need to share the desktop. Is better than share the presentation.
Can you see now? Okay.
Yes.
Yeah.
So this is the right eye, and we can see here drusens, and so in this area of that it seems like an atrophy in the center of the fovea. And here is the left eye with all those yellowish deposits, drusen, some pigmented lesions also in the center of the fovea. Here's the autofluorescence showing hypoautofluorescence in that atrophic area for the right eye with hyperautofluorescence on the border. And here is the autofluorescence in the left eye showing some areas of hypo and hyperautofluorescence in the center of the fovea. So this is right eye. And here is the B scan of the right eye. And I thought this was a very interesting presentation of this atrophy. We can see discontinuity of the retinal pigment epithelium, but what we call or was called before as RP aperture. here's a, we also had some subretinal fluid. This is the OCT angiography. We haven't seen any signs of choroidal neovascular membrane. And when we scan the lesion in the inferior part, we can see those hyperreflective lesions above the Brooks membrane that Rosa has just commented today. On the Unfast OCT, we can delineate precisely the area of atrophy in the third image, in the up third image here. And in the left eye, the OCT show a serous PED detachment with some focal discontinuity in the RPE and some hyperreflective foci, intraretinal hyperreflective foci as well, and some hyporeflective lesions in the neurosensorial retina. Again, the OCT angiography didn't show any signs of neovascularization. And we can see here in the Unfast two areas of hypointensity correlating to those areas of discontinuity of the RPE. We can see here. So, I brought this case to discuss with Rosa her thoughts about RPE aperture, the difference that we have with RPE rupture, what are the main differences, and might have some thoughts in the explaining the physiopathology of those apertures. Recently, Dave Seraf in the ASRS meeting presented a paper about subretinal, intraretinal fluid in patients with non-neovascular AMD. And so I brought this case to illustrate that. Thank you.
Thank you. I think it's a really beautiful case of an aperture. As you mentioned, it's really important to differentiate from RPE tears, but those apertures are seen in cases with atrophic AMD or non-neovascular AMD. Normally, they originate in drusenoid PEDs, like the one we saw in the fellow eye, the left eye. We see already two areas of RPE defect. And the thing with these apertures or defects of the RPE is that there is a paper that describes the benign nature of these defects. They don't behave as as cases with geographic atrophy. When you have fluid below the RPE and above the RPE, normally the retina is quite preserved, and I think the title is Retain Visual Acuity in Defects of the RPE. And well, I think the problem is when this fluid goes away, and then the atrophy of the outer retina appears, and that's where we have decrease in the visual acuity. I don't really know why this type of lesions appear. Maybe it's like an apoptosis of the RPE because it disappears completely and goes away, but I don't really know. What I think is that you have some basal lamina deposits. You have reabsorption of these drusen. Like if you go to the fellow eye,
the fellow.
Yeah, so maybe you had there a drusenoid PED that collapsed, but you have some persistent basal lamina deposit there that maintains a little bit the structure, and that's why you have some preserved outer retina, because if you look at the outer retina, the lines are completely preserved without RPE. And they could be like that for many months or years.
Rodrigo, let me ask you, I think, of course, what's the age of this patient?
He's 76, I think.
Because I'm seeing, okay, the AMD is a possibility, but also because of these, they are so symmetrical, I would put in the differential a cuticular drusen, different type, with what they describe with the pseudovitelliform also as a differential, because I don't see many soft drusen to explain a drusiform kind of RPE detachment. Okay, it would be in the first place, but also the similarity, but of course with the micro apertures, but I would put in as a differential cuticular drusen with pseudovitelliform in both eyes.
Yeah, this patient came with me the first time, I think 2-3 weeks ago, but he had a fundus photograph from 10 to 15 years before, and he had those very big soft drusen in the macular area. We couldn't see any cuticular drusen. So he developed in the left eye, we still can see this PED, drusenoid PED in the left eye.
Yeah.
And then not only the atrophy, but it's quite unusual. Huh? In regards to this apoptosis of the RPE, as Rosa mentioned, nobody really knows why that it happens. But one of the explanations, at least from Giuseppe Kerkis, who was the one that first described those lesions, is that the distance between the RPE and the Brooks membrane, because of the high content of the drusenoid PD, could cause some ischemia to the RPE. The RPE couldn't get enough nutrients and oxygen, and so it can probably turn these cells to apoptosis or die, and then you have this aperture sign. So this was the case that I'd like to share, and now I'm gonna ask Daniel to start sharing his screen.
But
Daniel was a former fellow. He's now living in the south of Brazil, Rio Grande do Sul, and he has made some major studies and contributions with micropulse, and he's going to share a case with us.
Daniel, say something.
You're muted, Daniel.
And we don't know if your mouth is moving because you have a mask.
Yeah, he has a mask. Pollution, not the virus. Now.
We can't hear.
Well, better call him.
I thought that things like that happens only with old guys like me.
Saudades do projetor? Kodak? Carrossel? Não falhava. Queimava slide, lembra? Queimou um slide seu em aula? O meu queimou algumas vezes.
Saiu uma fumaça.
Tira o carrossel rápido.
The worst thing is when the carousel was turned off without...
Okay. 100 slides. Lost the lecture. The academy was like this before. Rosa were not born at that time. Aconteceu, né? Esquisito, tá mudo. He's mute. Não.
Rodrigo, did you call Daniel?
Acho melhor sair e entrar de novo, Daniel.
Daniel is in another state of Brazil. It's far away.
Daniel, se você sair e entrar novamente, talvez tentar, porque a gente não está te ouvindo.
O melhor é sair e entrar mesmo.
Vamos esperar mais um pouquinho.
Se sair, pelo amor de Deus, volta. Se sair. Hein, tá vendo? Não esquece de voltar. O cara sai, né? Que nem o Patel.
Você já viu aquele vídeo do cara que estava no futebol? O cara falou, sai e entra. O cara saiu da sala, fechou a porta, depois abriu a sala e entrou de novo. Foi muito legal aquele filminho do futebol lá. Sai e entra. O cara saiu da cadeira, foi embora, saiu da sala, depois voltou.
Tentar share desktop. Ele saiu de novo.
Ai.
Does anyone have
Oi, tá abrindo.
Opa. Rosa, what's the time there? She's mute.
The time?
Now, in your place. What is?
It's 10 to 3.
Okay. 3 hours. 3 hours and no more. 6 hours.
Yeah, hi. Now it's okay.
Yeah.
Vê se tá aberto lá.
Now it's working.
It's working?
Yes. Tira essa máscara.
Tá aí? A Lúcia já abriu.
Share the screen aí. Que não...
Okay, I don't know what happened here, but sorry. But again, so thank you very much for this invitation. It's always great to come back to Escola Paulista to present. Can you see my screen?
Yes. Not in the presenter mode.
Okay.
Now it's presenter.
Okay, so sorry for the delay. So we're going to present a case of a 48-year-old white male with decreased visual acuity in both eyes. So this is not related to the beautiful presentation from Rosa, but this is an interesting case because he has a 20/60 visual acuity in both eyes, and now everybody can tell what he has. So we can see here in autofluorescence the increase of hydrofluorescence, so hyperautofluorescence area, so decrease of pigment with telangiectatic vessels and very intense leakage on fluorescence angiography. As you can see here in the OCT, someone has the microphone. So we can see the OCT.
Só um minutinho, Daniel. Mariângela, você podia desligar, por favor, o seu microfone? Eu acho que está aberto.
Okay, so we can see here in the OCT, actually decrease of the reflectance in the outer retina with no ellipsoid zone visible on the scan. So this obviously this is MACTEL type 2. The question that I made when I had this patient and the first time he visited my clinic is what we do with this type of patients. So this is around 2000, I don't remember, maybe 12, 13 or 14. We can see by the white on black OCT, which is the trend, and it was very fashionable back then. But we didn't have much to do with these cases. We knew that anti-VEGF didn't work. It actually could make it worse. Conventional laser photocoagulation could actually be worse too. We have scarring of the center of the fovea. So what we were doing back then, and we still do, it's endpoint management. So this is a case that we perform non-damaging laser photostimulation of the retina with these parameters, and we treat all over what they call the McTell zone, which is a broad treatment, not only the vessels, because we're not treating the vessels itself like a conventional photocoagulation. We are treating the whole area surrounding the fovea with almost 600 burns. So this is the first, sorry. So this is the baseline. So this is 2014. This is 4 months later, 5 months later, and this is the baseline, and this is what we have after 5 months. So this was very interesting result, and this we're starting to think about what could actually be happening to have this kind of restoration of ellipsoid zone. So this is after 12 months. Actually, we published this as a case series in this paper in the IOVS, trying to understand how the non-damaging retinal laser photostimulation works. And the actual visual acuity of this patient got better 2020. It was 2060 in the baseline. And this is after 18 months. And this is after 24 months. Still 2020, we see this lesion, this hyper-reflective surrounding actual temperature to the fovea, which correlates to the hyperpigmentation spot that you can see in McTell patients. But here in the INFAS, we didn't have the baseline INFAS, but we can see the decrease in the area of the ellipsoid zone disruption, which is the endpoint that we are using on clinical trials, both from the McTell group, from the CNTF trial, and to what I'm going to show very quickly here is the paper that we published actually this month, last month, that because of these cases that we did, was like, I don't remember, like 6 cases that we had a good result. We started to try as a randomized sham clinical trial. So one eye we would treat, the other eye we would do sham laser, and the patient didn't know which kind of treatment he received in each eye. It was completely masked, double masked trial. And we can see here, this is another case, a different case. That's why I brought the old case, but this is the new case that we did with a swab sourcial CT. This is the baseline. This is the baseline of the patient with the decrease, with the disruption of the ellipsoid zone. You can see here the lacunae, and you can see in the INFAS the area of disruption, that we can actually measure this area. And the OCTA too, with the typical telangiectatic vessels. But we can see this is 12 months later. We can see that this patient also had at least partial restoration of the ellipsoid zone. Still some inner retinal changes altered. And you can see in the INFAS the decrease of the disruption area, which is the endpoint we are using. And you can see in the patients that this is the result from the paper. We can see the decrease, significant decrease over time in 12 months of the area, the relative area from the treated patients. And we can see the stable, but a trend to increase the area of the ellipsoid zone disruption in the sham treated eyes. And also we did some function analysis. This is the COMPASS, which is a fundus automated perimetry. It's not microperimeter, it's not a microperimeter, but it has the same principles of microperimetry, especially the eye tracker and the correlation with structure, in this case with IR imaging. and we saw in the paper that sham patients had a decreased central sensitivity compared to treated eyes, but most importantly, we saw that the treated eyes had a smaller fixation area, so a stable fixation compared to the sham. So this is an important function result. Visual acuity was stable throughout the whole year, so it didn't change in both treatment, either laser or sham, but the fundus perimeter was different, statistically different between the groups. That's it.
Daniel. Não, primeiro é a Rosa. Rodrigo. Eu quero saber por que apareceu essa coisinha no meio, esse no build effect. Apareceu para todo mundo?
Apareceu, atrapalhou um pouco.
Então, apareceu, só para você saber, Daniel, seu caso é fantástico. Apareceu um obstáculo no meio, no build effect. Atrapalhou um pouco só, mas deu para. Eu queria que a Rosa falasse.
O que apareceu?
Apareceu um retângulo escrito no build effect, bem no centro de toda a apresentação. Um pouquinho, não? Pegou um pouco só, mas atrapalhou no final. Mas
I think it's the screen where you choose the sound of the Zoom.
Falou alguma coisa do som, Daniel. Não deixa acontecer. Rosa, what do you think about his findings?
I think it's really beautiful work. I've never tried, so I have no experience, but I was wondering why you think it's so effective.
So our main theory is that we are stimulating the RPE, but also we have stimulation to Miller cells. So we know that McTell is a Miller cell disease. Good. So we can experimentally with rabbits, with this type of laser, we got the expression of GFAP. So we got expression of Miller cell activation. So we can actually bring new or activated Miller cells to the area of the damage. And this would actually pull from the surrounding of the lesion viable photoreceptors, and they would migrate. So this migration we showed with laser. So intense laser, but not too intense, can actually cause migration to the photoreceptors surrounding them. And this is mediated by Miller cells. And this could actually be happening. Also, the RPE stimulation could stimulate also chaperones or Hitchcock proteins that can cause neuroprotection. So we know that this type of laser can stimulate neuroprotection of the RPE and photoreceptors by Hitchcock protein and crystalline proteins and other stimuli. So, but the answer is that we don't know. So the final answer is that we don't know exactly what's happening, but all laser therapies are based on theories. We don't actually have a very direct response for anything.
The only thing I saw in your case, Daniel, is 20/60 is really, really bad vision. I imagine near vision, how bad it is. So I think you should pay attention also to the kind of cystic alteration in your cases, because sometimes we have, I don't know why in Brazil we have cases that the cystic formation is in the outer retina. Sometimes it starts there, but most of the other cases, they start at the inner retina. So it would be something to look at, because I don't know. But the only thing I know is that we know so little about this McTell, because your findings are fantastic. I'm gonna send you some cases if I have one. Or do it here.
Daniel, let me ask you something. Do you think that there is more space for other subthreshold laser therapy in this situation? Because you tried one type, but there are many other types of subthreshold, barely visible, micropulse, endpoint, etc., many kinds of other laser therapies that would be useful in this situation to treat whatever is causing the edema or the cystoid spaces. It doesn't matter if outer or inner in the MACTEL, because we don't have a definite treatment for that. But do you think that there is a space for other kind of laser therapy?
Yes, I think every type of laser that can deliver low energy, so it's either by micropulse or by continuous wave, but with decreased energy, like endpoint management or other types of laser. If we deliver the right amount of energy, that we don't kill the cell, only stimulate the cell, but actually do something. So this is important. The algorithm is actually to actually do something. You can use anything you want. The important thing is to have the right amount of energy delivered to the RP, mainly to the RP. So this is the most important thing, because sometimes if the micropulse, you use a recipe that doesn't mean anything to the cell, it won't work. So that's why we developed this algorithm to try to deliver the right amount of energy to stimulate the cell.
Okay.
Thank you, Daniel. Congratulations on your work. So with this, we finish our meeting. I would like to thank very much Rosa for sharing her time and expertise with us. And we look forward to have other meetings and exchange programs between our institutions.
Thank you so much.
Okay, thank you so much. Be safe, everybody.
Yeah.
And Rosa, thank you so much. In name of our university and the department, I can say that we appreciate very much our participation. Thank you.
We'll keep in touch and keep collaborating.